Right, afternoon, everybody. We've had a cock-up. The cock-up was that, as I understand it, we did part one of this last week at 12:30, and part two was going to be 12:30 today. And then 10 minutes into my talk today, when I just said there are far fewer people here than I thought there were going to be, someone sent me a message saying I've got a link that says 1:30. So some people had a link that said 12:30, some people had a link that said 1:30. So we'd already started, and I didn't want to waste the time of the 10 or 12 people who turned up for 12:30. So we did the talk, and we're just going to do it again now, because likewise, I don't want to waste your time either. So often when you go to the theatre or a musical or something like that, I'm always in awe of these people who do this at sort of 2 o'clock in the afternoon and do the whole show again at 8 o'clock in the evening. Well, I sort of feel, I know how they feel now. So we're going to be doing some of the more advanced bits of dental negligence this week. We did the more basic stuff last week, terminology, records, that kind of thing. So this will be a bit more in depth. I was going to talk about implant claims. I was going to talk about nerve injury claims and perhaps some of the subtleties about them. Much more interesting for me if there's some kind of sign of life at the other end of the technology. So if anyone's got any questions, just don't be shy, just ping it into the chat. Having said that, people seldom do, in my experience. Happy to answer any questions by email or anything like that. Just you'll find me easy enough. Just send me an email and we'll happily deal with it. This is the plan. The plan is to have a look at that first slide, first of all, that sort of radiograph we see from time to time. What on earth's going on in that first slide, see how much of that you've worked out. Then we'll look at nerve injuries, implant claims. Now, I'd said that I would look at experts in the second talk. I did some of it in the first talk last week, so I'll reprise that and say a couple of other things about experts. And those of you who joined at sort of about 12:28, 12:29 will have heard me finishing off for the previous group. The expert stuff. So let's have a look at that first slide, first of all, and we'll get onto nerve injuries and what gets complicated about them. Right. So let's have a look at this first slide, get myself a pen. Right. Almost a full house of negligence in this slide, and quite an unusual one. It's quite old now. For those of you who do a lot of this work, you will already have worked out that this is an unusual bridge. We have lower left 3 here, and we have a cantilever on the 4. So far, so good, and a cantilever on the 5. So you don't need a degree in dentistry to work out that any sort of pressure on this is going to put massive tilting forces on this, and this isn't going to last 5 minutes, this kind of thing. To be fair to whoever did this, as I understand it, there was originally a 6 here that was supporting this bridge, but that was lost and it was cut through and they left it this way. That's not going to work. So that in itself, most of you will have identified that that's not going to work. And then we've got a post here. And most of you who do a lot of this work will know that you can't have a post without a root filling. And we haven't got any kind of root filling in this tooth either. So there should be a root filling there, completely obliterating that root canal. Otherwise, the bacteria that live in here from when this was originally devitalized, this tooth, and from bacteria that get round past this post will come out into the bone at the end of this tooth. And you see that there, you see this radiolucency here, a rarefaction, and that is because bone is being damaged, bone is being lost, and the bone is being damaged by the bacteria. The body's immune response can't deal with it. As fast as the immune response deals with these bacteria, more come from inside that space in the root canal, and you end up losing this tooth. What makes this slide truly remarkable is none of that, but it's this here. And this, some of you won't have seen these, they're unusual to see. That's a mandibular fixation plate. This lady had fractured her mandible some 25 years previously, and it had been repaired and repaired very nicely. And her mandible was no longer moving around, and she'd forgotten all about it, really. But when this bridge failed and this infection got around to the bottom of lower left 3, you can guess what happens next in the doomsday scenario. This infection gets into her mandibular plate, and she ends up losing her mandibular plate and had to have it removed. She suddenly found that her mandible was moving in 2 parts, very much like it had been 25 years previously. So that mandibular plate had to be removed and redone. So not a common slide, but it does show some of the things that we see, and pretty traumatic for that person to have to go through another mandibular fracture and repair. So let's move on to the nerve injury claims. What do we see? Well, it's really all about wisdom tooth extractions, nearly always about wisdom tooth extractions. This is upper right 8 for those of you who are here will remember from last week, and those of you who have just come to the advanced course will know this anyway. Upper right 8 wisdom tooth is there. That one's a bit impacted. They're very often much easier than that to take out. That's upper left 8. Dead easy to take that out. You just slide an elevator up the inside of that and you'll push that backwards and that'll be out in 5 seconds. There's no difficulty with that. Lower wisdom teeth can be a completely different story. And you can see an impacted lower right 8 here, almost at 90 degrees, buried into the back of the 7. Very difficult to get that out of that with bone lying over the back of it. So what injuries do we see? Well, we see lingual nerve injuries and we see inferior alveolar nerve injuries. Much easier to say Ian or IAN for the inferior alveolar nerve. And we're going to talk about the difference between those two and what injuries we see and how what breaches of duty cause those injuries and how we can mitigate against that, and how you would claim them and how you would defend them. So the lingual nerve. The lingual nerve supplies sensation to the tongue and the gum on the tongue side of the teeth. So not a particularly important piece of gum, but a very important bit of tongue. Often described as the anterior 2/3 of the tongue. The posterior third has got a different nerve supply. Now, it's important that it isn't the taste nerve. Taste is supplied by different nerves from the brain. Glossopharyngeal, principally facial nerve mainly. But some of the fibers are carried along with the lingual nerve where it's near the wisdom teeth. So you very, very commonly see taste disturbance and taste loss in patients with a damaged lingual nerve after a wisdom tooth extraction. It's not universal, but it's pretty common to see it. Here's the anatomy. There is lower right 8, the same wisdom tooth we were looking at before. Okay, so this is the inside of the mandible here. So the tongue would sit about here. And here is your lingual nerve trundling down the inside of the mandible. And it's not in bone, it's in soft tissue. Okay, so here's that lower right 8 again. Here's a cross section of it. There's your lower right 8. Here's the bone on the inside, the bone on the cheek side, the buccal side. And in that soft tissue here is your lingual nerve. That's where it sits. So it's in soft tissue, it's not in bone. And if you're going to be chopping this tooth up to get it out or drilling away this bone to get it out, then it's not a stretch to see how these lingual nerves become damaged. You have to drill away bone, you have to remove the overlying gum, the mucosa, and the periosteum, which is a sort of layer which is tightly bound to the bone there. And in raising a flap there, that's fine. But you raise a flap this side, you've got a real risk of damaging this nerve in raising your flap. And we'll look at how people should be mitigating against that just now. I've said the first 3, it's not the taste nerve. It's often damaged in wisdom tooth extractions. We see quite a lot of these, and it's normally nearly always when bone removal is needed. So people are probably thinking, why do you need to remove bone to get wisdom teeth out? Well, I'll put it on the next slide for you. There's a wisdom tooth. It's another lower right 8. You can see the angle it's at, not quite 90 degrees, this one. Here's the 7. It's buried into the back of the 7. So it's impacted into the 7. So you're going to have to relieve that impaction by cutting that bit off there. It's got all this bone above it here. And you're going to have to remove some of that bone to get this to come up. It's got nasty little curve roots here. Look at that. There's a curve on this. Something like that. This root doesn't even show on the x-ray. They haven't managed to get the x-ray far enough back. But you can see that root. So that root is probably going to snap off about there. If you're not careful, that's going to snap its little hook off. That's going to be difficult. So you need to get this bone away. You're going to have to probably cut through it there, lift that bit out, drag these bits forwards, and then lift them out that way. You're probably even going to have to separate that from that to chop that into 3 pieces. But you do need to get rid of this bone. So if you were thinking, why do you need to drill away bones to get teeth out, wisdom teeth, that's why. So To avoid damage to the lingual nerve, there are two schools of thought. There are two schools of surgical approach here. The first is, we know that nerve is there, it's nearby, we know it's at risk, let's protect it. Let's find it, identify it, see it, and then put a metal protector in. Often called the Howes retractor, which was designed for something slightly different, but works very well. It's just a slip of metal that goes down the side between the tooth and the lingual nerve. And the theory is your drill can't now touch that lingual nerve because it's got a bit of metal in the way. And there are many surgeons who operate that way. I've seen people operate that way and done it myself in the past, and it works very well if you're careful. There are those, however, who say, hang on a minute, if you start putting retractors down next to nerves and you retract things, you can cause an injury by putting too much tension on it. You might nip it with your retractor, crush it with your retractor. Best just to leave the blooming thing alone and go nowhere near it. So this second school of thought of surgeons will say, let's just approach from the buccal side. Let's go nowhere near this lingual nerve. If you've got to remove bone, let's do it all from the cheek side. Okay, might be a bit tricky because you've got to get the cheek out of the way, but let's get this cheek out of the way and do all of your bone removal from the buccal side and go nowhere near the lingual surface, the lingual plate of bone and that lingual nerve. And if you don't go through the lingual plate of bone, then you can't damage the lingual nerve, is the theory. So that's what those surgeons will do. Either is bolum defensible. I mean, it is classic bolum. That, you know, that's what bolum is. There's more than one way to skin a cat. It's the courts allowing clinicians to have two different approaches, and one isn't right and one isn't wrong. They're both defensible, and they're allowed a genuine difference of opinion about how to do it. It's exactly what bolum is. And bolum, as you know, was all about ECT in the 50s, 1957, I think, wasn't it? And flipping off operating beds when you had ECT applied to your head. Some people tied people down to stop it happening. Some people didn't because they said that caused injuries, and that's how bolum came about. This is as classic bolum as you can get. And use a retractor or don't go anywhere near it. Okay, what happens when they're damaged? Well, once they're damaged, these patients get numbness. These patients get a numb tongue, and they often bite that tongue because they don't know quite where it is, and they nip it quite regularly between the cusps of the upper molars and the lower molars. Interferes with speech. It's important to say that the lingual nerve is not a motor nerve. It does not provide motor power or motor innervation to the muscles of the tongue. That's done by the facial nerve, and that's nowhere near here. That's up in your parotid gland. So how do people say it interferes with speech? Well, it's really because they can't tell where their tongue is. They can't feel where it is. So they feel that they're not speaking properly. And your body works a lot on what's called proprioception, which is feedback from the muscles and tendons and all sorts of things to say what position things are in. If you stand in one leg and close your eyes, what's holding you upright is proprioception from your tendons and muscles so that they know when you're losing your balance. And the tongue does the same. It sends feedback. And if it can't do that, you don't know quite where it is. Loss of taste, I've talked about. You do get loss of taste and you do get disturbed taste in these patients. You do get some who don't, but the majority do. Now, the worst affected of these patients are those who've got numbness and dysesthesia. And dysesthesia is pain from the nerve. And you would think, wouldn't you, if a nerve was numb, how can it be painful? If it's like it's had a local anesthetic from the dentist and the tongue is numb on one side, it can't be painful, but that's not the case. They can be painful and numb at the same time. And they get dysesthesia, which are often electric shock pains. They might be permanent. They might come and go. They can be quite debilitating when they happen. And they get another thing called allodynia. And allodynia is a pain response to a normal stimulus. So you could brush the tongue with some cotton wool and they will say, ow, because the nerve is misfiring. It's not hurting them, but that's how it's perceived. I once did a talk at the British Association of Oral Surgeons in Belfast, and Max Fack's surgeon came on after me, was talking about lingual nerve injuries, and he called these people the most damaged patients in dentistry. I remember him saying that. And he says they really don't recover very well. They're often very twizzed by the whole thing. You often get psych reports. And in a sense, it's a type of chronic regional pain syndrome. It's a chronic pain syndrome for many of them, and they don't recover very well. So, what breaches of duty do we see that lead to these lingual nerve injuries? Well, the first one is should you be taking the thing out in the first place? Is there an indication for its extraction? Now, we're all used to NICE guidelines. We all refer to NICE guidelines all the time. Many NICE guidelines are, in fact, what's called a TAG, a Technology Appraisal Guideline. And in 2000, the very first technology appraisal guideline from NICE on any subject at all, the very first one, TAG 1, was about wisdom teeth. That was in March 2000. And they've been producing tags and guidelines ever since. But the very first one was wisdom teeth. And they said, there is a risk when you're taking out wisdom teeth of damaging the RAN. There is a risk of damaging the lingual nerve. There is some morbidity associated with it. Don't take them out unless. And one of the big factors was 2 episodes of infection or more. Because if you get 1 episode of infection, often called pericoronitis, you might never get another one. And if you take out teeth that have only had 1 infection, you're running a risk that isn't outweighed by the benefit. So you need to have 2 episodes of infection, and they need to fit into the NICE guidelines. There are others, but you'll find it easily enough on the internet. I won't bore you with all of that. But the principal one is 2 episodes of infection. What else do we see? Well, in the consent obtaining, I see people warning that there may be numbness, but not specifying that it may be permanent, or even specifying that it may be transient. So that's a very different thing. If you're going to have a wisdom tooth out and be told that you might be numb for a few weeks or months afterwards, you'll think one thing. If you're going to be told that you might be numb and it may be painful forever, you might think a different thing. So I do see consent forms that do not specify that it may be permanent, although that's going away now. I'm seeing it's being done better and better by clinicians now. Then we see this warning and then reassuring thing. And I see a lot of this in all walks of medicine. And it's a surgeon thing, is this, I'm afraid, to beat up surgeons. But what they tend to do is to give the warning, to say, oh, you may get permanent numbness, and then rip away that warning by saying something like the old classic, but it never happens in my hands, which is effectively saying you don't need a warning because it's not going to happen. Or saying, but I've never seen it happen, or something like that. And it's really not a warning at all. So if those of you who deal with surgeons and talk to surgeons all the time, they need to be careful about this, because I do see it an awful lot, perhaps not as much in oral surgery as in other walks of medicine, but giving the warning and then stripping it straight away by saying, but it won't happen, is not giving a warning, and it can leave people in trouble. So we need to put an end to that if we can. And what are the breaches? Trying to protect the nerve and failing. So these are the surgeons who use retractors. They place the retractor, and yet there's still, when someone looks at it 6 months later or 12 months later, there's a hole in the lingual plate because the drill has gone through the lingual plate. It's missed the retractor. And Howith retractors themselves are not that wide. And you need to keep your drilling to a fairly narrow area if you're going to use a Howith. So it's still a breach of duty if you use a Howith and miss it. What was the point? If you use a Howith, you've got to restrict your drilling to that area. So that's one breach we see a lot of. People say, I can't have damaged it, I used a Howith retractor. And very often the best evidence in these cases comes when there is a surgical repair or an attempted surgical repair. There are some repair specialist hospitals in the country. Tara Renton in London and Sheffield are the 2 big repair centres that I can think of. And they do try and repair IANs, and they do try and repair lingual nerves. And very often, when they open things up to try a repair, they will be able to show you a photograph of quite what the injury was. And we do see a lot of lingual nerve perforations when there was a retractor used, because people have missed the retractors in the wrong place. Those who don't use a retractor and the plan is to stay buccal, well, then you should be nowhere near that lingual plate. And again, you should have no perforation to the lingual plate, because you were never going that side, and people have just gone too far with their drills. And they do get a bit of traction, these drills. These are slow burrs. They're not high-speed drills, not that whining noise that you associate with the dentist. You can't use those on bone. They will burn the bone. These are water-cooled drills, which are much slower. And so they've got a bit of torque and traction, and they can run away with you, but you put them on a surface and they'll tend to run ahead. So that can happen quite easily when you are drilling bone, that you intend to go 4 millimeters from here, and the thing will just, your round burr will will speed away and you'll move 5, 6, 7 millimeters without intending to. The last breach of duty for lingual nerve injuries is not referring for repair. Those who do carry out repairs, Sheffield, Tara Renton's crew, and the like, will say, get them to us within 4 or 6 months, and we stand a chance of putting some of this right. Leave it 18 months or so, and we can't do any good. It's too late. And so that can be sort of the final nail in the coffin for these things, is people tend to cross their fingers and hope that this will get better, because traditionally lots of nerve injuries do get better after a long time. But let the specialist determine that is what they should be doing, and saying, let's get you off to the specialist repair centres now. And if they want to wait 12 months to see if it gets better, they can wait 12 months. But if they think intervening now gives you a better chance. Very rarely, I can't think of a case where I've seen the numbness go away from a repair, but I've seen many cases where the dysesthesia goes away after a repair. And that puts people in a much better place. They've still got their numbness, but if you've got rid of your dysesthesia, you're in a better place. A lot of patients don't want to undergo repairs. They are done with surgery on their lingual nerves and their IANs because they're given fairly stern warnings that it may not work. It may make things worse, because it may. You start messing around with any nerves, you can make it worse. So a lot of them don't undergo it, and I'm not sure they can be blamed for that. But those with proper dysesthesia who do undergo it normally see an improvement in their dysesthesia, but not their paresthesia, their numbness. Right. Oh, I was going to warn you. I know it's called Law with Lunch. I've got a couple of videos here given to me by Julian Yates, professor in Manchester many years ago. I'm grateful to him for allowing me to use them. But if you're squeamish, you might want to look away now. If you're eating a sandwich, you might want to look away now. The first one is very short, and it shows, A, how difficult it is to see a lingual nerve, although if you look very carefully, you'll see it. And it shows how close to the socket of the lower 8 it is. And then the second one is a repair of a nerve. It's a quite long video, it's 4 minutes or something, but I'm only going to show a little tiny bit where you'll actually see them bringing the two ends of a severed nerve together. And you'll see how small and fiddly this is. So the first one, he's trying to show you with the probe, you'll see where the lingual nerve is. If you look very carefully, after he zooms in, you'll see that it looks a bit more yellow, shining through the skin, if you like. So he's showing with the probe, the lingual nerve's in there. There's the socket. And it's just that yellow band that you can see just shining through. It's very difficult to identify, but that's how close it is. This is just repeating now. It's a very short clip, but it's in that skin there. And that's why it's important to get that away, keep away from that, or place the retractor to keep away from that. This second one, I'm going to fast forward to about 1 minute because you'll see the repair. I need to turn the pen off. Give me a moment. This one does get a bit gruesome. Let me fast forward it to a minute. Okay, you're going to see the two ends of it's a fully transected nerve, this, completely cut right through. Here's the top end of the nerve here. He's got hold of it with these tweezers. There. Here's the lower right 7. Here's the tongue. And he's going to find, there's the other end of your nerve, and it's been completely cut through by someone taking out a wisdom tooth. And he's going to put them together like that. And for scale, that is a lower right 7 there, which is pretty tiny. And you probably even can't see it. There's a needle going through here. He's putting a needle through this end of the nerve there. There's your needle. Going through that end of the nerve, and he's going to sew it to the other end of the nerve. And I think in total he puts in 3 sutures here to put the two ends of this nerve back together. So all you're going to see is just more of the same. Yeah, just sewing the two ends of this nerve together. But you can see how difficult it is to see and difficult to even identify the nerve. And there you go. That's the last suture going in, putting that bit of nerve with that bit of nerve. So it can be done. Right. Okay. That's lingual nerve injuries, and they're bad enough. We see inferior alveolar nerve injuries as well, and it's a completely different nerve. This nerve supplies sensation to the teeth, to the lip and the chin, and that skin around there, and the gum on the outside of your lower right 321 in the case of the right inferior alveolar nerve. It's a completely different nerve to the lingual nerve. It sits deep in bone under the teeth. The lingual nerve, remember, is in soft tissue along the inside of the teeth. The inferior alveolar nerve is deep in the bone underneath your teeth. Let me show you. So here we've got, this is, I need to put my pen back on, don't I? Pen. So this is tooth, this lower right 4, lower right 5, lower right 6, lower right 7. This is some of lower right 8. These are the roots of lower right 8, a tooth that we'll talk about why that might have happened in a few minutes. That's lower right 8. And here is a canal in the bone, which has been partly highlighted in red here. And it trundles all the way down. So it basically comes from the base of your brain up here, and then in soft tissue, and then it goes into the bone there, stays in this bony canal. It comes down underneath all of your teeth. There's a hole in the bone there, and it pops out a branch called the mental nerve, and that supplies your lip. And then it trundles on in the bone, and it supplies a branch to each of these teeth. And when you get toothache, that's the nerve that's giving you toothache in your lower jaw. And you may never have noticed, but when you have a filling done in your upper jaw at the dentist, let's say upper right 5 needs filling, they will just put some local anesthetic near upper right 5, about there. The bone is dead thin, it's wafer thin. Wait 3 minutes, that anesthetic will get through the bone, and lower right 5 will not feel anything. You can drill a hole in it, and it'll be fine. The bone in your mandible, what's going on here? It's moving all by itself. The bone in your mandible is much thicker, really thick bone. You can put as much local anesthetic near lower right 6 as you want. You can put a bucket of it there, and it's not going to get through that bone, and it's not going to get to lower right 6. So what you do is you aim here. You put your needle at the back here, where this nerve where it goes into the bone. So it doesn't matter which tooth you're getting filled in the bottom arch, you will nearly always get the same injection at the back, and that's why it goes numb right round to the midline. You can't knock out this nerve along the way because it's buried in deep bone, thick bone. Your mandible is very strong to withstand trauma and blows, whereas your maxilla has got the nose in front of it to protect it and for other reasons. So you'll always get the same injection, whether you're having lower right 7 filled or lower right 3 filled, you'll have your injection right at the back here. Your tongue will go numb on one side because it gets the lingual nerve, because you know that that's down here on the inside in the soft tissue, and it knocks out the inferior alveolar nerve there. Okay? So I've said that, it's deep in bone. This, for those of you who were here last week, this is the comedy slide I put up at the start, the sort of welcome slide, the OPG radiograph with the sunglasses on. And even on that slide, you can see on this, just a normal OPG, you can see the canal here to some extent. And you've got a difficult wisdom tooth there. Look at the bend on that wisdom tooth. That's going to be naughty to get out. That's an 8 or 9 out of 10, that one. And you can see the canal here. You can actually see the top of the canal there. And you can see the bottom of the canal there. And that's where your inferior alveolar nerve runs. It gets more complicated here to see it. You can probably just see the mental foramen there, the mental nerve where it pops out there. So you can see it on x-rays. And when we talk about wisdom tooth extractions, that's important. So what breaches do we see? The first two are the same as lingual nerve injuries. Not warning that it may be permanent, warning then reassuring. I'm not going to repeat myself about that. Now then, this is different. When you take those x-rays, they are a 2D representation of a 3D object. They will not show you if there's a true relationship between the roots of lower right 8 or lower left 8 and that nerve in that canal. They will show you that there's an apparent relationship. If we go back to the previous slide, you will see that those roots are not very far away from that canal. But that's only in 2D. You may not, in 3D, it might be quite a long way. So if I've got my 2 lower roots here, you don't know, and here's the nerve, you don't know if it's this side, whether it's this side, whether it goes between the roots, which it does often. And there's no way of knowing on a 2D representation. So this is all about what to do if you've got an apparent proximity. Okay. If you've got an apparent proximity on 2D imaging, then you just don't know. And the duty is to 3D image. Now, if you're A high street practice, you're probably not going to want to do that. You're going to see the apparent proximity and you're going to get rid and send this off to someone who does it all day, every day, and can't do fillings, but can only take wisdom teeth out. What's the point for the high street dentist of taking that risk? There are some practices out there that do nearly all oral surgery. So the NHS subcontracts a lot of this back out. So most areas you will refer to an oral surgery referral unit and it will choose where it goes and it will send a lot of it back out to a specialist high street practice. And they will take the imaging, but they may not go as far as taking 3D imaging. But if you've got an apparent proximate relationship, you need to know whether you've got a true relationship. I did a trial about one of these and a couple of days was spent dealing with the difference between apparent relationships and true relationships. So you take your cone beam CT scan, and if it's not truly related and it's just an illusion on your 2D, press on, take out your wisdom tooth. That's fine. You're not going to damage the IAN. If it is related, you need to stop and you need to think. And if there's a true relationship or it runs between the roots and you're at real risk, you need to think again about that. And you need to send it off to someone who's going to be very careful taking out that tooth and is a super specialist, if you like, and only does that kind of thing. Or you need to be thinking about alternatives. And that's where coronectomies come in. Let's have a look at coronectomies. I retired from dentistry in 2004 and I'd never heard of a coronectomy. So it gives you an idea of how recent they are. Last 20 years. This is just Latin, coronectomy, Latin for crown. And Latinectomy just means taking out. Otomy means taking part of something out. An ectomy means taking all of it out. So this just means taking the crown out. And the theory goes like this. Here's this wisdom tooth. This is a full-on 9 out of 10 that one. Nasty little hook on that root. Some bone trapped in the middle, bendy root there. It's got what we call a distal impaction. A mesial impaction is when it's buried under 7 here. This is a distal impaction. This has got bone over the top. That bone there is stopping this coming up to extract. There's a distal impaction and difficult to get out. You need to get rid of quite a lot of bone there, and then you're going to have trouble with this. And you've got a very close inferior alveolar nerve canal, like that. It's got just about every neon warning sign it can have. That very difficult extraction. So the theory goes, well, why risk damaging this inferior alveolar nerve and giving someone lifelong paresthesia and dysesthesia? Why not take the top off this, slice it there, and then just leave all of this alone and take the top off here? Because people get infections around them. There's a shadow behind this. That's the infection in the bone because you can't clean underneath the gum. That's why they get pericoronitis, because the gum sits over the top. You can't clean underneath it. People get constant infections around wisdom teeth. That's why they have to come out. So if you get rid of the crown, you get rid of the source of infection, and that will be the end of it, is the theory. And here is it done afterwards. Crown has been sliced off here. Leave these roots alone. This will heal over. That, frankly, will be blooming sore for a few days. You've got live nerve in each of those canals, which has just been truncated. You've got a pretty sore wound. I wouldn't fancy having that for 3 or 4 days. But 3 or 4 days of that compared to a lifelong of dysesthesia, a life full of dysesthesia, it's a bit of a no-brainer. So that's why they're done. They don't always work because in chopping it up and taking off this bit, you might mobilize these bits. And it's okay to realize that you've mobilized it and think, well, it's moving now. Let's pop that out of there. You can't do it if there's decay. If this tooth has got a thumping great hole in it here and there's bacteria in it, there will already be bacteria in these roots around here. So you can't do it if there's significant decay in the crown of the tooth. And then very often these roots will move. So you might do this coronectomy and years later, these roots will migrate north and come out all by themselves or come to the surface. It's very common in high street dental practice to see old people who had all of their teeth taken out in the 50s, 60s, 70s, and they've had full dentures for 25 years. They will come in with some pain and you'll look and there's a root coming to the surface, and it will be the end of a tooth that was broken during extraction in the 50s, 60s, 70s. And it's come to the surface, and it's dead easy to pop it out, bit of local anesthetic and a pair of tweezers, job done. If these roots migrate to the surface 5 years from now, 10 years from now, so what is the theory? You'll be able to nip them out very easily with a pair of mosquito forceps or a pair of tweezers, and they'll have migrated away from that nerve. And you'll do no harm to that nerve. They'll automatically come away from it. So that's the theory about coronectomy. There are cases where it's been admitted that it's a breach of duty not to offer a coronectomy. And it's one of these areas of dental negligence that's evolving because, as I say, 20 years ago, didn't really exist as a recognized technique, but it is now. And it's become a recognized technique because everyone is realizing better the impact upon these patients who end up with a full-on nerve injury. So coronectomies are out there. If you're defending these, you should be saying they don't always work. If you speak to the oral surgeons who try them, lots of the time they can't make it work, and they mobilize the whole tooth when trying to do a coronectomy. They often don't work because there's caries around or gum infections around or the like, and they're not always appropriate. If you're running these claims, be careful about whether there's caries there, whether it's appropriate. Not all wisdom teeth are appropriate for coronectomy, but some are, and it probably should be offered to some people who are at high risk. And everyone who has a wisdom tooth out has got a level of risk of nerve injury. There's a whole subclass of these claims, which I call elevated risk cases, where you take your 2D imaging and or your 3D imaging and you say to someone, you're a much higher than average risk. You're really at risk here of getting a life-changing nerve injury. Let's try and avoid it. And those are the people you should consider coronectomy for. And so it's all about their level of risk. Right, that's covered coronectomies. How are we doing for time? 20 minutes. Implant claims. Right. Implant claims, again, relatively new. Okay, I wasn't a dentist in an affluent area of the country. I had a couple of practices in Sunderland, and I saw one dental implant in my career, retiring in 2004. They were around, they were rare. Certainly in Sunderland, they were rare. And I only saw one. And frankly, it was a shambles as well. But they are relatively common now, and we see quite a lot of claims about them. For those of you here last week, let's have a quick recap and just make sure everyone's on the same page. Here's an implant. Most of you who are here for this second week and not the first week will know all about implants, but let me just address it anyway. As we talked about last week, around a normal tooth, you have a ligament around the tooth, the periodontal ligament, which provides some real resistance to bacteria. It takes years for that ligament to be damaged. That's what periodontal disease is. It's a slow, insidious disease that no one really notices, and it takes years. With an implant, which is sterile titanium, just drilled in this, you drill a hole into the bone, you put the implant in, and the big discovery was that bone will grow onto sterile titanium. It will actively grow and creep across the surface and bolt the thing in to the bone. Many of these implants have a hole around here, and the bone will grow right through it and lock that thing in there, and it's not going anywhere. But there is no ligament. If you get bacteria on the surface of your teeth and you're not cleaning it properly, and it comes down the groove, as we talked about last week, once that gets round here, it's got no ligament to protect it, and very quickly you will get infection around your implant. While periodontal disease can take years, implantitis can take months. That's a different shot of an implant. Here's your implant in the bone sticking out the gum. This is called an abutment, which screws into it, and then the crown either cements on the top or is screwed onto the top. And the fit between this crown and this milled surface is so tight and so retentive that they tend to last really well, much better than normal crowns. In general, and maybe a topic for another day, implants last for life in general, as far as we know, but they've only been around 30 odd years, so we don't know if they're going to last 50 or 60. The abutments will last the same. The crowns will wear out and need replacing every. People have traditionally said 15 years. Most experts will now say 20 years. There's more recent research that they fit better than crowns that fit on natural teeth. So they tend to last a bit longer. And of course, they can't get decay underneath them because there's no tooth surface to decay. There's just metal surface. So this is what implantitis looks like early doors. It's just gum inflammation like gingivitis. It's called mucositis. Once it starts to spread down around your implant, it's implantitis. And very quickly, that implant will be gone. This is an implant bridge. This is an implant retained crown, an implant retained crown. This is the pontic, the false tooth. So there's a whole one unit metalwork covered in porcelain. And there's an implant up there, and there's an implant up there. And you can see this redness here. The gum is purple there underneath. The gum edge is raggedy and red. That's bleeding. You touch that with your finger or toothbrush, it will bleed like billy-o. Plaque is getting down around the side of that implant, and you're getting implantitis. And if you don't fix that, don't get under there and clean it, and if your patient doesn't keep it clean, that implant is going to be lost. Not only will that implant be lost, but then once that becomes loose, it will put massive forces on this one as well. Okay, so that's what happens. What breaches do we see? Well, very often you are placing implants in someone who's lost teeth because of periodontal disease. Now, if the ligament has been damaged over years, and if the ligament can't resist it, the periodontal ligament, then sure as eggs is eggs, you're going to get implantitis around your new implants if they haven't had an epiphany and if they haven't changed their plaque removal and their oral hygiene habits and all the rest of it. So you need to fix the periodontal disease first. And you can only place implants into stable mouths. If you just take out a disease-ridden, periodontal disease-ridden tooth and replace it, you will very quickly have a periodontal disease-ridden or implantitis-ridden implant. And when it goes, it will take a load of bone with it as well. And you will need to do grafting, or you may never be able to put another implant. So most implantologists will say, you're not having an implant from me until your periodontal disease is stable. It is okay to place implants at the same time as removing a periodontal involved tooth, but you've got to curette the socket. You've got to clean that socket of the bacteria which you know were there. Okay, but it is not okay to place implants into a mouth where you've got unstable periodontal disease. You are just asking for trouble. It's inevitable. Putting it bluntly, putting an implant into a dirty mouth is going to fail. You have to have a spotless mouth. You have to have people who've fixed their perio and have got the lowest plaque scores, bleeding indices, and all the rest of it. Smoking really damages blood supply to the gum and the bone. And if you damage blood supply, you damage the immune response. And immune response damage causes implantitis, periodontal disease. And also, it masks one of the signs of periodontal disease, which is bleeding. Gums bleed when you've got periodontal disease, and if you smoke, you tend to see less bleeding. So people tend not to notice it. And the same with implantitis. Very often, a complaint of patients who've just stopped smoking is that their gums are bleeding. In fact, their gums have been trying to bleed for ages because their oral hygiene is not good enough. But now they've stopped smoking, the gums are able to bleed better because they're not cutting down their blood supply. So they need to stop smoking, or at the very least abide by a smoking cessation protocol where for X number of weeks and months they don't smoke around the placement. What else do we see? Not enough bone for the implant. This is back to the 2D versus 3D thing. If you take an X-ray, it might look for the world like you've got enough bone, but that is a 2D picture of a 3D thing. And if in doubt, you should be taking 3D CBCT scanning so you can look that there's enough bone all the way around. And I see lots of cases where it looks on X-ray like there's enough bone, but when someone takes a CBCT of a failing implant, there was never enough bone. So lots of people not scanning when they should be. We see angulation problems. I'm going to show you slides, by the way, of all of these in a minute. I've got an example of each. Angulation problems. If you're going to place an implant bridge over two implants, they're going to have to be parallel. If one's at that angle, one's at that angle, you are not going to be slotting something over the two of those. They need to be parallel, even if they're both like that, but they do need to be parallel. So we see lots of angulation problems. For many years, there was a lot of talk about surgical guides. Lots of experts now say they're not essential, having said for years they were, because we now have this kind of technology planning where you can put the CBCT scan into the software. The software will tell you where to drill, where to place your implant. So there is a defense to not having surgical guides now if you've used sophisticated, dedicated implant planning software, whereas even a few years ago, it was very difficult. What else do we see? Sinus perforations. You've got huge sinuses in your cheeks here. It's basically just air. And it's very easy to pop an implant up into those. And for those of you who've ever had proper sinusitis, and I mean the sort of sinusitis where if you bend over to tie your shoelaces, your head hurts because it starts throbbing in here because the fluid is moving around in your sinuses. Your top back teeth can hurt, all of them, because the roots of your top back teeth almost go up into your sinuses. So if you're replacing an upper six, it's very easy to put the implant up into that sinus. We see nerve injuries in the lower arch. We've talked at length today about the IAN and where it is. It's very easy to put an implant in the mandible and drill it down into that IAN. I'll show you a slide of that. Aesthetics problems. There is a metal collar between the implant and the crown. At the back of the mouth, that doesn't really matter. No one's going to climb in and see it. But at the front of the mouth, in some patients, it's really important. This sort of anterior zone here is often called the aesthetic zone. We only show so much of our teeth when we're smiling and talking. Some people like me won't show an awful lot of tooth at all. It's partly age, you lose elasticity in your tissue. Some people will show all of their front teeth and a lot of gum above that. And in them, if you're going to place an implant in an upper one position, an upper central incisor, and they've got a high smile line, you're going to struggle to provide great aesthetics with an implant because it's likely you're either going to see some of the metalwork or you're going to see the metalwork shining through the gum. So people need to be very careful about aesthetic assessment first and warning patients about what to expect. Like so much of dentistry, it's about expectation management and telling people what is likely to be a problem. And if it doesn't turn out to be a problem, great. It's the same as your job and my job. Expectation management is really important. So let's look at an example of each of those. Here's an angulation problem. In this one, it probably doesn't matter. That's the angle of the lower left 5. This is replacing a 6, but they're not going to put 2 implants in to replace a 6. It's normally a 2-rooted tooth. But you should be at the same angle again. So it should be in line with that green line there, but it's not. It's in line with this one. Actually, in this tooth, it probably doesn't matter too much because you can buy angled abutments, the abutment there. You can change the angle of that, put it on like that, and you can still put yourself a nice crown on there. But if you were going to have a bridge here, and you have one at that angle and one at this angle, you're stuffed. That's not going to work. So there's a classic angulation problem. Here's a sinus problem. The sinus, you can see it in your mandible, in your maxilla here. There it is. It's got another locule to it here as well. And here is an implant well into the maxillary sinus. So that will have been punched through the bone into the sinus, taking with it as it goes bacteria from the mouth. And there will be bacteria in this sinus. And if I remember rightly, a denture was screwed onto this for someone who couldn't retain an upper full denture. And they were delighted with the denture, but they were not delighted with the 3 or 4 years of permanent sinusitis they got from having the implant in the sinus. This was done abroad, this one. The implants on the left here are not too bad. All the same, all pretty much lined up. One of them just engaging the cortical plate of the sinus, but that's fine. That's really dense bone. You can actually see that white line there. This white line here is called the cortical plate, and that's great. If you can tap into that, you can get real strength from that. On this side, however, we've got lots of different types of implants, lots of different angles. That one's at that angle, that one's at that angle. Very long, very short. This one up into the sinus. But what you can do, if you don't have enough bone here, you can do a sinus lift. So you literally go into the bony sinus, lift up the lining, place bone there, like that. And it gives you more room to put implants further up if you need it. And that's what they tried on this side. But the real point of this slide is this. This is all artificial bone. This is all bovine cow bone that was placed in an attempt to do a sinus lift. And they basically filled the sinus with bone, artificial bone. So, as I say, I think it was done in Hungary or somewhere like that. I think this one, if I remember rightly. But that's what that is, artificial bone where they filled the sinus. So you've got that breach of duty, that all had to be removed. If I remember rightly, all these implants on this side had to come out and be redone. You couldn't restore this side whilst you're waiting to get that side fixed. So even though these were good, you couldn't do much with it. So another example. This is some of the most remarkable dentistry I've ever seen. This is an unusual type of implant called a one-piece implant. It doesn't have a separate titanium screw and separate abutment. It's a one-piecer. The important thing to see on this slide is this. A wing there, and the wing goes off over there. And here it is in picture. That's it. So it's an implant that goes in, and it's got these sort of comedy wings, which I've never seen before or since. Again, done abroad, I think. It's got these comedy wings here, which stick out. First of all, the bite was wrong. Look at all those scratches in the porcelain at the back here. That's where a drill has been used to change the bite. And they've drilled so much away that they've gone through to the metal. So they're through to the metal. And they were worried that because the bottom teeth bite in behind that, they were worried that this tooth would get forces which should push it that way. So to mitigate against that, they've put these wings in here and here. Remember what I said, you've got to keep this implant plaque-free completely. There's no way that you will keep that plaque-free with that surface there and that surface there, and you'll get implantitis around that, and that won't last 5 minutes, that implant. And in fact, that's what happened. It was lost fairly quickly. But I would hope you wouldn't see dentistry like that in Britain. I've never seen the like, but it illustrates the point nicely. These are the nerve injuries we see in implant placement. It's got a mind of its own today, this thing. Here's the IAM we talked about at length earlier. You don't need a degree in dentistry to work out that if you put your implants too deep, you're going to compress that and ping that. And your mental nerve is down here as well, which I say is a branch of the IAM. Very easy to ping that as well. So we do see those injuries in the lower arch. And finally, a word about experts. We've got 6 minutes left, something like that. A word about experts. Those of you who were here last week, forgive me, because I'd forgotten that I promised to talk about experts in talk 2. So if anyone's come along to just talk 2, I thought I ought to cover experts. I'm just going to reprise what I said last week very quickly, and then talk about something else about experts. Be cautious. There are a lot. I'm going to use the word suboptimal. There are a lot of suboptimal experts in this field. I see a lot of poor expert reports. There's a whole group of experts who are poor in writing, but fine on the phone if you ask them the right questions, but they can't seem to put it into writing. There are lots of experts who don't understand the test, and they will say things like, a reasonable body of dentists would do this. Whereas, of course, the test is, would no reasonably competent body not do it? So they tend to get that mixed up. Obviously, use like-for-like experts. A GDP needs to be judged as against another GDP. For implants, there is no specialist register. The GDC declined to have a specialist register for implants. And now it's not playing at all now. Right. The GDC declined to have a register for implant specialists. So the best you will do is find someone who calls himself perhaps an implantologist or a dentist with a special interest in implantology. But you'll find them easily enough on the internet, but there won't be specialists as such. You get endodontists and prosthodontists and oral surgeons and the like, but you won't, and periodontologists, but you won't get implant specialists. I don't like experts being told what to do. I've moved on a point. I'll come back to that one. I don't like, if you're for claimants, I don't like asking experts questions at the start. I think you get lazy reports. They tend to just answer your questions and don't look at everything in detail. And you might miss things. They might miss things. They get a better understanding of the case of a whole if they actually don't know what it's about, apart from you've told them. You can tell them which teeth it is, but let them figure it out for themselves. And for defendants, exactly the same. Because if you just ask them questions, or well, and I fully appreciate they will be dealing with the allegations that have been put in the letter of claim and or the particulars. But if they only deal with that, they tend to, for me, they tend to lose context. They tend not to look at everything else because it's all about context. Yes, there might be a breach with lower right 5, but in the context of the dentition of a whole, it might be absolutely immaterial. And if they haven't looked at the context of the dentition as a whole, they won't understand that. So for both claimants and defendants, try not to be prescriptive. Just give an idea what it's about and let them work it out themselves. And I promise you'll have better conferences, you'll have better reports because they've paid more attention to it rather than just answering the questions. Big bugbear of mine, proper hobby horse, this one. Experts reporting when there are missing documents. And we covered missing documents last time. What happens is this. They're all busy clinicians. They've taken a morning off to do that report, a week on Thursday or whenever. That time has been set aside. There's no patience for that time. They'll sit down to do it. Within 10 minutes, they'll realize that something's missing. There are notes missing, there are radiographs missing, but they've booked this time out to do it. So they get on and they do it. What they should be doing is getting in touch with you and saying, I can't do it. I need these x-rays. I need these documents. But the time has been set aside. What they should do is have two looks at this. One, spend 15, 20 minutes working out if you've got everything. If you have, then you report on it at a later date. If you haven't, stop there and go back to instructing solicitor and say, I need this, 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 and this. The number of times I'm instructed and I say, well, we need that, 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 and that. And when we got them, the expert changes their mind because they just didn't know that those documents existed or they hadn't looked for them. So make sure you tell your experts, if you haven't got everything you need, just stop and then we'll get it and then you can report afterwards. It really does make a difference. I said this last week, declarations are important. The protocol for the instruction of experts was replaced in 2014. That's now 10 years ago. And this week already, what are we on Wednesday? This week already, I've seen 2 or 3 reports that quote that protocol that's been out of date for 10 years. Now, I've put this to experts in witness boxes before, and a few judges have said, Mr. Hill, effectively, that's a crap point, move on. A few judges have said, no, I'm really interested in this. I want to know if an expert is out of date by 10 years and doesn't know that a protocol disappeared 10 years ago. I want to hear about this. And I've won one trial where I'm pretty sure that was that. My opponent said, this is immaterial, this is a cheap point. But the judge, who wasn't a clin-neg judge, just said, no, this is really important. I want to know how up to date they are. So don't let them put in stuff that's 10 years old. We'll just give them a hard time about it. The opposition will give them a hard time about it. And really, I've got a preferred standard set of declarations and statements of truth, and they should all just be using. You should have one yourself and just say, if you don't know what they are, just use this and just give it to them, because it just makes them look poor if they're out of date. For both claimants and defendants, don't let L&C evidence creep into your C&P reports. There's a good reason we don't disclose L&C evidence early on in litigation, because things come to light. Arguments come to light, documents come to light, and your experts can make fools of themselves by saying what they think at that early stage. Formally, of course, they've got to say it earlier on for the letters of claim, letters of response, but don't let it creep in unless you absolutely have to. Conference agendas, I don't like conference agendas. Again, that makes them lazy. And really, a request from an expert for a conference agenda is just tell me what I need to do, because I'm not going to do much more than that. And I would just say you can be asked anything about the whole case. It would be the answer. And that feeds into this point here, going back to experts. What happens is this: they write their reports, they spend a lot of time, a lot of energy, and they think that's it. They think they're done. 18 months later, you come back to them and say, we've got a letter of response or a letter of challenge. Please, can you look at those? If your opponent has got a good point, it's going to be in that documentation. It's going to be in that letter of challenge or in that letter of response. And experts tend not to give that a lot of time. They tend to skim through the report, and you all have seen these emails that say, I don't change my mind. Nothing in that causes me to change my mind. One line, yours sincerely, and that's it. You'll all have seen that a lot. They really should be taking a lot of time at that stage, in my view. And the number of times they write that, and then later we have a conference, or close to trial we have a conference, and they're surprised that they said that because they didn't pay attention. So there's danger at that stage for me that your experts are not engaged with the case properly. They were when they wrote the report, they are at conference, they are at trial, but when sent a new piece of paper, they don't engage well. But if I were you, I'd make sure they do, because that can cost you in the end. Last 2 points. Experts at trial. I once had a trial about a hip replacement, and my expert was going to use a toilet roll tube from the middle of a toilet roll and a pen to explain to the judge how you align your stem in your hip replacement. And the other expert was using a flip chart with photographs and pens and lovely drawings and all the rest of it. And there's no doubt which expert managed to capture the judge's attention. It doesn't happen often, we know that. None of us go to trial that much. But when you do, it's important. And I think your experts should be encouraged to get their pens out and draw and explain this kind of stuff, because that's what they're there for, really. Everyone forgets the only reason that we're allowed this opinion evidence, which is what it is because the court can't make up its mind without opinion evidence. The better that opinion evidence, the better. And if they're drawing and explaining, it really does make a difference. My final point. What's not in an expert report later in litigation is often really important. If you're at trial and there were some allegations in the letter of claim that never made it to the particulars of claim, and if I'm for a defendant, I want to know why. I want to know how they came to be there in the first place. Was there expert support for them, or has the expert changed their mind on something? I think it's a really important point. If you're for a claimant, and things go into your letter of claim that don't make it into your particulars of claim, I think you're causing yourself a problem. The answer by many claimant solicitors will be, come on, Mike, 1% less, go to trial. Most of these claims settle. It's not really a big deal. But for the ones that do go to trial, it can become a big deal. So it's really a defendant point as much as anything else. Just pay attention to what's disappeared. And so often in life, it's not what you're being told, it's what you're not being told. So it's an interesting point when you get close to trial. What's disappeared and why is it disappeared? And it can put some pressure on people. And it works for claimants as well. If defendant experts are protesting in the report and it doesn't make it into the joint meeting, the joint statement, then yeah, it's a powerful point for claimants as well. So look, I hope that's been helpful. I'm terribly sorry if it was a bit mixed up when you joined in, that you thought I was finishing off. I was. You have to forgive me, my voice is going a bit now, 2 hours straight of doing that. Feedback is always good. Let me know what was good about it and bad about it if you like. Always happy to answer questions or give me a ring about any of this kind of stuff. And thanks very much for your time. And I hope that's been helpful. I'll leave you all to it.